detection and intervention. So, with the advance in technologies and research, the number of preterm babies who are surviving is on the rise, and also that too with less number of comorbidities. So, this topic is central in optimizing the outcomes in child health, particularly in the context of this neurodevelopmental disabilities. So, to take us through this topic, we have Professor Ashraf TP. I'm proud to say that he was my teacher, and he has played a pivotal role in shaping the child health and disability services in the state. He initiated the hearing screening programs in the Kerala and was instrumental in introducing the rubella vaccine into the public health system. His leadership as a superintendent of the Institute of Maternity and Child Health and as the project director for Kerala State Initiative on Disability and Healthcare has been truly impactful. He also pioneered the Shruti Tarangam project, which was brought innovative support to the children with hearing disabilities, including the provision of free cochlear implants. His work extends beyond the healthcare into areas of economic assistance and social rehabilitation for the differently able, and he continues to serve passionately at the Early Intervention Center at the Government Medical College, Kozhikode. So please join me in welcoming Professor Dr. Ashraf TP to take this session. Over to you, sir.
Thank you, Dr. Rahul, for the nice introduction. First of all, let me thank the organizers for giving me this opportunity to talk on early detection and early intervention of neurodevelopmental disorders in children. Actually, Dr. Ashil talked about the preventive strategies and global perspectives in children with disabilities. After that, we had a very good session on genetics and the role of genetics in the diagnosing, managing, as well as preventing the neurodevelopmental issues. But again, now we are in the ground. I am stressing only the clinical medicine, something you can see with your eyes, something you can hear with your ears, and something you can palpate or touch with your hands. Because the investigations or neuroimaging or a genetic testing may not be applicable to all. And normal children as well as no abnormal children are there. Normal children and children with some issues will come to you. So the clinical differentiation is very, very important. And some of the early clinical clues, even before the lab investigations, that may not be delineated, but the subtle changes will come first in most of the neurodevelopmental issues. So detecting or seeing or hearing that subtle changes is very important, not only for doctors, but also for all the therapists who are working in this field of disability. Because you are seeing the children more than that of doctors. You are spending more time with these children. After the parents, the therapist spends a lot of time with children. So I am touching that aspect only. We are running short of the time. It's a general definition. What is a neurodevelopmental abnormality? It's a disorder due to impaired brain growth and connectivity. That word is important because in a neuroimaging, in an MRI, in a CT, in some condition you can see some of the changes. But the defect is in the connection. These things may not be seen in neuroimaging. So connectivity affecting motor, language, cognition, behavior or social interaction. All these disorders comes under the neurodevelopmental disabilities. Then these are the common risk factors, some of them prenatal and many of them perinatal, and even the postnatal issues can lead to such developmental issues. Then, Dr. Ashil already pointed about the plasticity of the brain. The brain is more sensitive to your early stimulation as well as the early intervention techniques in the first 2 to 3 years of life. Later it become more rigid or concrete. So that is a very critical period to intervene. So without an early detection, we can't intervene early. That is the importance of early detection, and it will give you an opportunity to support family education and planning services also at an early stage. Then these are some of the screening tools, because one of the commonest manifestation of neurodevelopmental issues in children are developmental delay, and most of these screening charts are based on the development. Then these are the roles of therapist. Observe development during therapy session. You will get enough window for that. Apply simple screening tests. Teach parents stimulation activities. That is very, very important. You are spending 30 minutes or maximum 1 hour with children. The mother is spending all her time with children. So teach parents about the stimulation activity is very, very important in the early intervention. And the last line is very, very important. You may be a doctor, you may be a physiatrist or a physiotherapist or an occupational therapist. You also, me also, may have several ignorance about the child, about the science also. So it is a teamwork. If you are working as a single professional, only a speech therapy center, but you can develop a teamwork by coordinating with other group of specialists in your area. So any therapy, anything in the disability is a teamwork. So whenever you are having a doubt, refer the child to the expert, the concerned expert. That is very, very important. All the facility may not have such facility like Tunnel Super Specialty Center. Here, there may be all the professionals are there, but this is not applicable to all centers. So whenever there is a issue beyond your knowledge, beyond your expertise, don't hesitate to refer. That is very, very important. Then, we all know, I'm not going to detail, and these are some early red flags. 3 months, no smile, poor head control. By 6 months, not rolling, no social response. By 9 months, not sitting, no babbling. By 1 year, not standing, no single words. By 18 months, not walking, not pointing. By 2 years, no 2-word phrases, poor eye contact. All may be a early feature of neurodevelopmental issue. But other clues are also very, very important, which may be a general feature, which may be a tone abnormality, either floppiness or stiffness, which may be a feeding difficulty, or a loss of a skill, a regression. So of course, if the child is having a microcephaly or a macrocephaly, small for gestational age, large for gestational age, the risk for neurodevelopmental issues are more. That child should be kept under the follow-up, regular follow-up, either in the well baby clinic or in a high-risk baby follow-up clinic. Then cry, that is the most important activity of any newborn. So, if the baby is excessively irritable, crying always, screaming throughout the night, it may be due to neurodevelopmental issue. There may be other causes also, but one of the important cause you have to exclude a neurodevelopmental issue. The vice versa is also important. If the baby is abnormally calm, chance to have a neurodevelopmental issue is more, including hypothyroidism. Luckily, fortunately, we are now having a thyroid screening program under the government, but most of the time the result will come after 2 months or 3 months. It is a very, 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 very important period. So the clinical follow-up is also important. Then feeding, one of the most important activity by any kid. Lot of feeding issues may be a early marker of a neurodevelopmental issue, like poor sucking, tongue retraction, persistent bite or tonic bite. The mother is saying it is very difficult to latch out. If it is persistent, it may be a pointed towards a spastic cerebral palsy or other neurodevelopmental issue with an increased tone. Every baby occasionally may have a persistent bite, but if it is may have a tonic bite, but if it is persistent, think about a neurodevelopmental issue. The tongue thrust is also important. Tongue thrust means if the baby is trying to push out the nipple from the mouth repeatedly, persistently, it may be a feature of a early feature of an extrapyramidal cerebral palsy. Then grimacing, frequent grimacing, drooling, frequent vomiting, aspiration of feeds, all may be a early marker of a neurodevelopmental issue. The alterations in the muscle tone may be presented as a stiffness or a floppiness or poor mobility or fixed postures, like quantum of movement is less. The baby will exhibit all sort of movements if he is not sleeping. But if the quantum of movement is less, it may be a pointer. Paucity or asymmetry of the movement. If the baby is moving left hand but not right hand frequently, it may be a hemiparesis, early feature of hemiparesis. At that time, CT may not show any features, especially in the early months. So, in the early months, the subtle clinical features are more important than costly investigations. Persistent cortical thumb beyond. By 3 months, old baby will open his hand. If the baby is keeping thumb persistently across the palm, even after 8 weeks, it's a red flag. Persistent fist beyond 10 to 12 weeks, difficulty in wearing diapers, or poor mobility, preferential unilateral hand use may apparent by 6 months. Usually the handedness will develop by 2.5 to 3 years. Before that, the baby will use both hands indiscriminately. Handedness means discriminate use of one hand. If it appears early, it may be a pointer towards the hemiplegic CP. Abnormal crawling, asymmetrical crawling, or movement problem, uncoordinated or involuntary movements, writhing tongue and fingers and toes, facial grimacing, head staggering, tremor on reaching, and some of the associated features like poor eye contact, roving eyes, poor hand regard, persistent skin, refractive errors, lack of auditory response, dysmorphism, small head or large head, constipation. Constipation is one of the consistent feature with the children with a neurodevelopmental disability. You think about the intestine, you think about the brain also, especially if it's accompanied by other subtle changes. But this word is very important. Don't make a comment to mother, your baby is abnormal, by seeing some of the subtle abnormal physical findings, especially in the early months of life. That is first 4 to 6 months of life. The baby's brain has enormous capacity to develop newer synapses. It is so, since control of movement does not occur until late infancy, diagnosis may not be confirmed until after 6 months of age. Then, intervention definitely is a teamwork. Bretley is there. Bretley is a hearing ambassador for the cochlear company. All will have role. So the early identification and early intervention, better developmental outcome. Therapists are frontline partners in detecting and managing neurodevelopmental issues. The Tunnel, many other voluntary organizations. This quote from Stephen Hawking is very important. My house and my workplace have been made accessible for me. Computer experts have supported me with an assisted communication system and speech synthesizer, which allow me to compose lectures and papers and to communicate with a different audience. But I realize that I am very lucky in many ways. My success in theoretical physics has ensured that I am supported to live a worthwhile life. It is very clear that the majority of people with disabilities in the world have an extremely difficult time with everyday survival, let alone productive employment and personal fulfillment. This is very, very important. ആക്ച്വലി ആ ആശംസ പറയുമ്പോൾ ഞാൻ തണലിനെ പറ്റി ഒരു വാക്ക് പറയാൻ വിചാരിച്ചിരുന്നു. സമയക്കുറവ് കൊണ്ട് ആശംസ ഒഴിവാക്കി. അപ്പം തണൽ എന്ന് പറഞ്ഞാൽ ഇഫ് യു ആർ ട്രാൻസ്ലേറ്റഡ് ഇൻ ടു ഇംഗ്ലീഷ് ഇറ്റ് ഈസ് ഷെയ്ഡ്. അപ്പം തണൽ ആവശ്യമുള്ള എല്ലാവർക്കും തണലൊരുക്കുന്ന ഒരു സ്ഥാപനമാണ്. ആവശ്യമുള്ളവർക്ക് മാത്രമല്ല, ആവശ്യമുണ്ട് എന്ന് അറിയാത്ത കുറേ ആളുകളുണ്ട് ഡിസബിലിറ്റിയിൽ. അവർക്ക് തണൽ ആവശ്യമാണെന്ന് അവർക്ക് പോലും അറിയില്ല, അല്ലേ? അവർക്കും തണലൊരുക്കുന്നുണ്ട്. അപ്പോൾ ഇത്തരമൊരു കോൺഫറൻസിൻ്റെ നെക്സ്റ്റ് സെഷൻ പോളിസി മേക്കിങ്ങിനെ പറ്റിയുള്ളൊരു പാനൽ ഡിസ്കഷനാണ്. അത് വളരെ നല്ലൊരു ഡിസ്കഷനായി മാറുമെന്നാണ് ഞാൻ പ്രതീക്ഷിക്കുന്നത്. കാരണം തണൽ ഈ ഒരു മേഖലയിൽ ഒരു ലീഡ് റോള് എടുക്കുന്നതിലുള്ള ആ ഒരു സന്തോഷവും ചാരിതാർത്ഥവും നിങ്ങളുടെ മുമ്പിൽ പറഞ്ഞുകൊണ്ട് താങ്ക് യു ഫോർ എ പേഷ്യൻ്റ് ഹിയറിംഗ്. ഇത് 200 കോക്ലിയർ ഇംപ്ലാന്റഡ് കുട്ടികളന്ന് നമ്മുടെ പ്രോഗ്രാമിൻ്റെ സെക്കൻഡ് ഇയർ അവർ ഇതിൻ്റെ വീഡിയോ ഉണ്ടായില്ല. സ്റ്റേജിൽ ഒരു പാട്ടിട്ടപ്പോൾ തുള്ളിക്കളിക്കുന്ന അതിൻ്റെ ഒരു ഫോട്ടോ ആണ്. വീഡിയോ തീർന്നിട്ട് കിട്ടിയില്ല. വീഡിയോ കുറേയും കൂടി അട്രാക്റ്റീവ് ആയിരുന്നു. കാരണം ഒരു ഏർലി ഇൻ്റർവെൻഷൻ ഹൗ ഇഫക്റ്റീവ് ഇൻ ഏർലി ഡിറ്റക്ഷൻ ആൻഡ് ഏർലി ഇൻ്റർവെൻഷന് ഗവൺമെൻറ് ലെവലിൽ നമുക്ക് പലപ്പോഴും മനസ്സിലാക്കി കൊടുക്കാൻ പറ്റിയൊരു പ്രോഗ്രാമായിരുന്നു. എസ് അഷിൽ പോയിൻറ്റഡ് ഔട്ട്. ആഫ്റ്റർ ദാറ്റ് വി സ്റ്റാർട്ടഡ് ദി ന്യൂനാറ്റൽ ഹിയറിംഗ് സ്ക്രീനിങ് പ്രോഗ്രാം. ഇറ്റ് ഷുഡ് ബി സ്റ്റാർട്ടഡ് ഫസ്റ്റ്. ആൻഡ് താങ്ക് യു. This is a child with a congenital rubella syndrome. If you are carefully look into eyes, you can see the mark of cataract, and in his ear there is a cochlear implant processor, and this child undergone PDA surgery. All these 3 interventions were supported by Kerala Social Security Mission under the scheme Talolam and Shruti Tarangam. Later we started rubella immunization. Rubella vaccine cost at that time only 40 rupees, but all this intervention cost around 8 lakhs. That is the importance of the prevention. Thank you for it.
Thank you, sir, for simplifying the topic early detection of this neurodevelopmental disabilities, and also highlighting the need for teamwork and appropriate referral at the appropriate time. So I think we'll take the questions at the end, and we'll move on to the next session.
Thank you, sir. So next session would be an online session by Dr. Arun K. Singh. He's a professor in HOD, Department of Neonatology, AIMS, Jodhpur. He's also National Advisor for RBSK. So we'll have his online session now.
Good morning to all of you. Am I audible?
Yes, sir.
Hello, am I audible?
Yes, sir. You're audible, sir.
Okay. Are my slides seen? Are they visible?
Yes, sir. The slides are visible.
Okay. Thank you. So today's topic, which I'm going to address, is early intervention in India: the journey, the challenges, and the future. Now, one of the most important challenges, we have different terminologies, different programs by Government of India, different ministries also. So somewhere we say DEIC, District Early Intervention Center. Somewhere we say CDC, Child Developmental Center. Somewhere we say DDRC, that is Developmental Delay and Disability Rehabilitation Center. DDRC comes under Ministry of Social Justice. DIC comes in Ministry of Health. So there are so many programs running. Sometimes they are overlapping and sometimes there is a confusion also. So let me try to clarify things the way I have perceived as a national advisor trying to set up the program of District Early Intervention Center. So, early intervention, the main idea is to improve the brain development of newborn. And the main idea is also to promote a healthy foundation for future. So, it key revolves around saving brains of newborns. Why is it so? Because in today's world, we are saving lot of preterms, lot of sick babies who may suffer from birth asphyxia. So should we wait till we find a developmental delay, till we find a disability, or should we intervene early? Those were the key questions and how it should be integrated in the current context. So the definition, very quickly, I would say it is a structured program of therapeutic services provided to infants and young children from birth to 6 years. Though I may say that we need to go beyond zero. That means the early intervention should start also in the fetal life. Why? We are not waiting for the developmental delay to manifest itself. We are not waiting for the disabilities to manifest itself. We are considering all babies who are at high risk and who are at the highest risk. Those who have spent their first month of life in any intensive care or have a birth defect for which they needed to be treated in the first 1 month of life. So, such children, we require a structured program of therapeutic services which will evaluate, which will, after evaluation, will make a decision and then do an intervention. And the critical period of 0 to 6 is the period of neuroplasticity, the new period of brain development. So it means providing therapeutic, medical, and supportive care as early as possible, even maybe to a fetus, and to help a child reach their maximum physical, cognitive, and social potential. So, what is the aim? Now, try to see when a newborn is born, he may have a medical problem. That medical problem may be a speech problem. That problem may be an eye problem called cataract. That problem may be a motor problem, which we usually see in cases of birth asphyxia, HIE, or cerebral palsy in process. So, here we try to very quickly evaluate and start treating while the brain neuroplasticity, that is about 100 billion neurons, are still arborizing with each other, talking to each other. So, early intervention is a program which does not allow a medical condition in becoming developmental delay or disability. Either it minimizes it or it completely reduces it. I have cataract, you have operated upon me, I am going to have full vision. So, this early intervention in a critical period allows me to see as any other normal child. So, or it may minimize disability. So, here there are lot many nuances which have to be understood if we really understand what we want to do in early intervention. So, it's a coordinated program. Now, the key it focuses on skill development. Age group is very important, is therapy based and goal oriented, and the services includes physiotherapy, occupational therapy, speech and language therapy, vision therapy. All this you have heard. Have you heard of a dental therapy also? Are you aware that dental caries in a pregnant woman can cause a preterm delivery, and this preterm delivery is at the highest risk of developmental delay? So, if I start treating in the antenatal period dental caries, I would be preventing preterm deliveries. If I tell the people that 37 weeks is not term because that was based on lung maturity and not on brain maturity, brain keeps on maturing till 39 weeks. So, if we define that actually term is more than 39 weeks, don't do a cesarean section unless until there is a medical emergency at 37 weeks or 38 weeks. This would change a lot. This would prevent a developmental delay or disability. So here the early intervention is also acting as a prevention. But if there is a problem, it can be home-based or center-based, and the aim is to maximize developmental potential by intervening. So, if this is early intervention, then what is a disability center? What is DDRC? So, I put it very simply. If you intervene in a health condition, which may be a medical problem, which may be a surgical problem, which may be a therapeutic problem, do the intervention either through drugs or through surgery or through therapy or combine all of them, and you prevent or minimize the health condition to change into a developmental disability. This is early intervention. But if by the age of 6 years, disability has set in, then your intervention is to prevent this disability from becoming handicapped. I'll give you a small example. I now cannot walk. I have to go to first floor. I have to climb a bus. So if you provide me with a wheelchair, this is preventing me from becoming handicapped. You're not curing my disability. You're not minimizing it, but you are enabling me to achieve something which, if I hadn't a problem, I would still. So it is a life cycle approach. It is a rehabilitation. Social justice was more about rehabilitation. The medical component, early intervention, focuses more before it becomes a disability, a permanent disability. So, early intervention is a set of therapeutic interventions providing early to prevent a health condition to become disability or minimize disability. Whereas disability and rehabilitation centers prevent disability from becoming handicap. Now, what about child developmental center? Now, CDC starts from if there is a developmental delay, where does the patient go? Where does the mother go? They can go to CDC. So the starting point is that there's some kind of someone has identified that there's a developmental delay, there's a behavioral issues, it requires, and here the age group is entire child, 0 to 18 years. Whereas early intervention focuses on the first 6 years or first 3 years at times. And this is usually hospital based or large standalone centers. And the team, which is very common with also early intervention, a developmental pediatrician, a pediatric neurologist, a psychologist, a physiotherapist, occupational therapist, speech therapist, special educator, nutritionist, audiologist, and so on. And this is where the services are being provided. So, if we remember anything, early intervention starts from 0 to 6 years, but in coming years, it would also include the fetal life. As we were just discussing, a lot of genetic issues could be intervened. Even things like thalassemia, etc., can be intervened during the fetal period. So that also should become part of early intervention, but there has to be a center. Now, the key component of early intervention are physiotherapy, occupational therapy, simple positioning. Now, I have an NICU. The usual outcome was that once the baby has been discharged from NICU, and if there is a developmental delay, then you send it to a center for intervention. No, we know that most of the babies who are in the NICU, they are at a highest risk. Can we do the positioning while they are on ventilation? Can we do an orthosis while they are in the NICU care so that we prevent it, or the information to the developing brain should not go that this is now an acceptable posture and we will intervene later on once the baby stabilizes. That means I want the physiotherapist, occupational therapist to go into the NICU, to go into the SNCU and start intervening there. Now, this is where at AIMS Jodhpur we had developed, and we had one house center which we are focusing for children from 0 to 6. So instead of having just a follow up of high risk newborns, we divided them into various age groups according to weights. So if you were born before 28 gestational weeks or less than 1000 gram, we would call you more frequently. And the sensory organs are the windows to the brain. So we would be very careful that evaluate the sensory organs before the mother comes and tells that I have a developmental delay. And also, this gives me information that how should I arrange my labor room? How should I arrange my NICU care so that such problem could be addressed early? So this center had in-house lab, ECG and EEG, neonatal ECG and neonatal EEG. If I had club foot under one, prosthetics, occupational therapy, pediatric dental, hearing, vision, all this was a part. And so you had speech and language therapy. But here the speech and language is not only about language. It starts within the NICU. Is the baby able to have an oral motor control? Can he swallow? If he can't do this, then waiting for the language to come would be too late. But here you have a combination of surgeons, medicine, and therapists in one place. Instead of going to different OPDs, the doctors come to this center. So you have an ENT, and they all work with very small children from birth to 3 years, essentially, at maximum up to 6 years. So you tend to understand a problem much earlier before the parents pick up. So the feeding and swallowing difficulty. Now, see, this is a common problem in CP babies. Should we wait for this problem to come in and then intervene? Or should I, in the field of neonatology, teach them that you require a faculty who knows about this, can come to you, and while you are trying for survival, takes care of intact survival by providing this. So at AIMS Jodhpur, we actually did with fantastic results. And this was under the program called Early Intervention Center, which is clubbed with the NICU, not with the pediatrics. So all sick babies, right from day one, all babies with birth defect are linked to the services of this multi, which has got equipments to evaluate the vision to evaluate the hearing, which is for such small children who cannot speak. So I will not take you into the details of this. I would invite that some of you should come, but just to share with you that our hearing equipments is not only OE and bearer, it is also various instruments which will help to do the auditory verbal therapy for also picking up the balance disorders. So this is your OA and MERA. This is the report. So all babies born here are screened. So birth defect screening should be linked with early intervention. Because if you are going to screen and get a child with a problem, he is the child at risk. So the hearing screening is there, the vision, and there's a very important chapter called cortical visual impairment. And I congratulate doctors from Kerala who have taken a lead in this cortical visual impairment, which was not understood a decade back. People thought that you are only to focus on the motor disorders of cerebral palsy, or in preterms, you only focused on retinopathy of prematurity. But cortical visual impairment is something where you can really help. Otherwise, you'll make the mistake of calling the child blind. And here, the occipital and the parietal lobes both are involved, along with the frontal lobe, in trying to see an object and process it. Squint, refractive errors, nystagmus, vision problems. So we developed an instrument by which we could capture the red reflex. We started doing fundoscopy for all children. You would say, sir, but it's a very costly thing. No. What is the cost of it if you discover later and prevent a child from becoming blind? If you discover early, while there is a neuroplasticity, even a deaf child can speak. Even a child with CVI would be able to see and make use, will not have to study Braille. Isn't that a great thing? But this has not been integrated with the medical science. Pediatricians think that saving a baby is good enough. And if there is a problem, they can go. No. It should be a part of their syllabus that if you're cooking the food, you jolly well taste it. So this is some of our fundoscopy, which we did in more than 10,000 babies in 3 years. And we found a lot of things which from top it would appear normal. We picked up glaucoma, newborn glaucoma, congenital glaucoma. You can see we picked up intrauterine infections through just fundoscopy. So we are not only screening the preterms, we screened everyone. And these instruments, you don't require doctors. You can train anyone with this. So this is our vision room. And there was no such space, you understand, in neonatology. So there was a corridor on the terrace. We converted that. So you can see our nursing staff, they have been trained to do fundoscopy. Our nursing staff have been trained to do the vision therapy. We had also an optometrist, but at times optometrists are not available. So this is about CVI. Yeah, they are dorsal stream, ventral stream. This is a talk by itself. I will not take you, but just to make you understand that the reticulostriate pathway is not the only pathway. There are other pathways from the superior collicles to the pulvinar to the posterior parietal cortex, which is equally important for the child to understand an object. The orthopedic, we very early, we tried to see what is the muscle spasticity, and I'm saying this within the NICU. So while you're doing cooling therapy for HIE, I'm also looking, is the child trying to develop muscle spasticity? Can we do an EMG in a newborn? You'll think all this is not possible. It is very much possible even in a government sector. But the science has to be taught. You prevent contractures, you prevent bone deformities, you prevent hip subluxation. Maybe it is a case of a CP, we can prevent scoliosis, we can prevent, and we did something more. To do the plasters of the club foot, we did not allow to be cut by scissors or by a saw or electric saw, because that was burning the baby skin, which is very tender. So we built a bathtub and a bath pool. The child would just soak his leg or her leg, and the plaster would come out. And there were toys there, and as you can see, there are stars at the top. And then we put on the next plaster without making the child cry. So the same child who had clubfoot, we also try to see if he has problem of eyes, he has problem of hearing, he has a problem of any psychological problem. A child with a congenital heart disease, we don't treat the heart disease as an entity, because the heart is a part of the entire body that is dictated by the brain. So we evaluate all other organs and try to maximize the potential. For me, this is early intervention where the medical, surgical, and the therapeutic areas merge. And I believe the government of India wanted this to be present in every district. So you can see, even for rural areas, we could make this. Even the dental chair is like a car, and we picked up among motor disability children with caries, and they were having malnutrition. So the dental problems, key components. And I'm very glad that while I was doing RBSK, I could convince Kerala, and Kerala was the first state in the world which started doing visible birth defects, functional birth defects, metabolic defects, and neurodevelopmental defects as a part of RBSK. Thank you very much. I congratulate everyone. And this has allowed your IMR to come down from more than 10 for last 25 years to now 5. Congratulations once again. This is the birth defect screening. This is a neurological screening. And these are all done while the baby is still just born in your NICU. The MRI without sedation, congenital heart disease, how to do ECG without making the child cry, what kind of analysis can you do bedside, whether it is the lactate analyzer. And this is another program we developed, the MCP card, in which we had 3 colors. Supposing the child is not admitted in the NICU, is there a chance that the child can develop a developmental delay? Yes. Now I don't require the gadgets. So this mother child protection card, this particular thing had been done by me only. So I can explain you what is the logic behind it. So the green color is something which the mothers see. This is developmental delay. A train has not arrived, you are waiting for the train. What about if the train is not, has derailed? That is developmental deviation. These are the red flag signs. And during this period, before you go to someone, what are you supposed to do during this age? These are the parenting tips which will help you. So this is a pictorial. I am not aware any part of the world has such a combination of these 3 colors. What to do? The mother notices if there is any delay, and the red flag signs, where any one of the signs you have to go to the DIC. So these are the key components: the medical treatment, the nutritional support, the counseling, the special education. So what I'm trying to say, 3 things are very, very important: the early periods, the period of maximum brain plasticity, the early therapy, which is helping your functional and participation and prevents long term disability. So now you can also go into the perinatal risk factors. So now I'm trying to find out how I can, even the fetus can be told even before the birth, are you going to have a problem? And how should I intervene? So the neonatal factors before and during pregnancy, during labor, and I'm just touching these points. I don't want, even the labor room design has allowed to prevent birth asphyxias. You would say, do you mean to say an engineer can do a change? Yes. An architect who changed the design of a labor room. There's a beautiful paper, and we did it. I did it in Andhra. And we found out that impact of birthing room design on maternal childbirth experience, it really changes. This, when to cut the cord, it allowed us to show that if you do physiological cord clamping the way the tribal people do, the blue line shows there is more oxygen going to the brain. The heart rate is much better as compared to if you cut the cord at 1 minute and 3 minutes. And you can do even intake cord resuscitation. One very, very important thing, if you forget everything, something which is in your hands, don't separate the mother and the child, even if you do a C section. Long before I was born, Professor Harry Harlow did a wonderful experiment to show that if a monkey is separated from the mother, the monkey doesn't only want milk. The mother, the monkey baby wants soft touch. And if the soft touch was given, there was a better neurodevelopmental outcome. But if the baby was given nutrition without that maternal touch, the baby developed all the features. You can go through the paper of what we call today the autistic and ADHD. These are the baby monkeys. So this shows that the human touch is very, very important. And this touch is an effective touch. It doesn't go to the area 312, which we have learned when, but if the mother touches the baby, it goes to the frontal lobe, to an island called the insular cortex, where through the slow unmyelinated fibers this area goes. So just keeping the mother and child together, even without cutting the cord, even in a C-section, will allow the best early intervention you can think of. And this has been seen that in the MRI, there is much better development of the insula. So these are simple things, but huge effect and not doing a zero separation. And this is the DIC. So there are three programs of Government of India under health. One is the District Early Intervention Center, which focuses, as I have told you, linking it with the NICU, linking it with the labor room, linking it with birth defect screening. There's a second program after 6 years, that is DDRC. You have to rehabilitate now. This is lifelong. There's a CDC also, which goes from birth to 18 years. And for normal children who are never admitted into ICU, that means those who are at low risk, you have the mother child protection card by which you can identify the developmental delay and how to prevent such a delay. You have a wonderful book, again under RBSK, The Journey of the First 1,000 Days, where it is said, what are your traditional practices which were good enough and prevented a development delay or disability? Thank you very much.
Thank you, sir. Sir, shall we take some questions from the audience? Arun, sir, can we take some questions from the audience? Okay. Thank you, sir. So with this, we conclude our session. Is there any questions?
Any questions?
Are there any questions, sir?
So there's no question from the audience, but can I have one question? What have been the most significant challenges in scaling up these early intervention services across diverse states?
Please come again. What happens?
What have been the most significant challenges in scaling up these early intervention services across different states?
Yeah, so the most important challenge is to get the proper equipments which will help you to evaluate. Trained people who are comfortable understanding a baby. So you may get a speech therapist from a highly good institute, but he may not be well versed with interacting with 0 to 3 years. You may get an ENT specialist who is very good at pediatric, but may not be so good for 0 to 3 years. So I think till we develop a center where we have a trained manpower, trained equipments, and then try to do multi-skilling so that we move away from the district to a sub-district and then to a rural level. So initially we require multidisciplinary approach, and this should be linked with the pediatrics department or with any private hospital also. If you are saving preterm babies, then you must have an early intervention center. You cannot just leave it, and intervention starts from the NICU. So doctors need to permit and treat the therapist as their own colleagues and understand the limitation of the medical science. As a professor of neonatology, this is very important. The child is important, not our egos. We do not understand everything. So if you require help, please take help, bring people there, but the baby is not going to travel. So proper equipments, proper training, and the and having the courtesy to respect as teachers other therapists in your department and creating such posts is very, very critical if tomorrow you really want not only survival but improved survival.
Thank you, sir. With this, we conclude this session. Uh, Thank you. Sir, could you just turn on the video so that we could see you as well? Arun, sir? Arun, sir, could you turn on the video, please?
I think it didn't make the sense which I wanted. Audiences, is it?
Audience,
Was it very confusing?
no, sir. It's just that we could not see you in person. Otherwise, the whole presentation was clear. We were wondering if you could on the video so we could see you at least on the camera.
I would have loved to come in person. I'm so sorry that I had to do this online. But the next time, I promise you, I would be definitely there. I would have loved everyone who is here to interact with them.
Sure, sir. Thank you. Thank you for a lovely session. And with this,
Thank you.
we conclude the session. Thank you.
Thank you, esteemed speakers, for highlighting the power of early detection and teamwork in shaping a child's developmental journey. We now invite Dr. Naveen Anushara, State Project Head, Kerala Center for Disease Control and Prevention, to do please present a token of love to our chair, Dr. Rahul Illaparambat and Dr. Mohammad Faiz.
Next, we have Dr. Salah Bashir, Clinical Assistant Professor, Child and Adults in Psychiatry, University of Nottingham, on the topic Integrating Research into Early Intervention Practices. An online session.
Everyone, happy Children's Day. What a great day to talk about early intervention in childhood disabilities. I would like to congratulate the Kratanal team for organizing such a great program, and I would like to also thank them for inviting me to present today as well. Hello, everyone. Happy Children's Day. What a great day to talk about early intervention in childhood disabilities. I would like to congratulate the Kratanal team for organizing such a great program, and I would like to also thank them for inviting me to present today as well. So, I'm planning to talk about integrating research in early intervention practice, and so I would like to kind of make give you a sense about why that is needed and what how it could kind of help to drive evidence base in the care as well as how to in terms of helping scaling up these intervention across. So coming topics which I would kind of want to explore in this talk is why are early intervention vital in childhood disabilities? You might have already heard about it, but I'll just try to kind of start the talk in that way. And also what's happening in the current research and what are the key challenges and how we could kind of overcome these challenges. So, what I'm trying to talk today is about early intervention from birth to 5 years. I know there are interventions and attempts to kind of work during the pregnancy period and in terms of targeting the maternal aspects, also looking at genetic aspects as well. But what I'm trying to focus is the 0 to 5 years of age. We know that the global childhood mortality has reduced, but there is lack of attention to kind of manage the problems in terms of the development disabilities, which are getting more and more in these days. According to statistics, there are around 53 million less than 5 years with various kinds of developmental problems like autism, ADHD, epilepsy, and intellectual disability. And this 0 to 5 years of age is quite kind of crucial in the sense that that's the period when the brain growth is maximum. It is quite plastic, and it is a time in the child's life which we could kind of potentially intervene to kind of help the development as well. We also should keep in mind this is also a period when any kind of insults, whether it's toxins or whether it's nutritional insults or whether in terms of insults like adversity, can also have a long-term impact. So this is a quite crucial period in their life. When you come that when you talk about early intervention, especially in low and middle income countries like India, there is added burden of stigma, there is more stress and financial strain as well. So what we hope with early intervention is really to kind of change these development trajectories so that it can have a long-term impact on the child as well as their families. So when we look at global research in terms of what's happening is that it is still limited, but it's growing. What we find is that when you give intervention earlier, that helps, and also when you give intervention in a more family-centric manner, in a more naturalistic manner, in a more playful manner, that also helps. So that actually has been found to kind of help with in terms of the developmental outcome of the child as well as parental outcomes. So there is this need for such scalable, culturally relevant models of care. I'll go to these specific models which are out. So looking at evidence-based global models in early intervention, we can see there are different models out there already. So coming to Jasper, which is developed in USA, which is actually a play-based model, which kind of targets social-emotional development, especially in young children with who are at risk for autism spectrum disorder. Similarly, when you look at PACT, which is a video feedback-based therapy, which kind of targets the mother-child synchrony, again targeting social-emotional development in children with risk for autism spectrum disorder, and this pact has been kind of being adapted to South Asian setting, and that's named as PAS. And this is kind of being delivered through non-specialist workers to make sure it is more cost effective. In terms of WHO's model, which is the caregiver skills training, and that this is another kind of early intervention which is available out there, and this is now being piloted in low and middle income countries. When you look at cerebral palsy specifically, there are again models which are looking at learning through everyday activities, which kind of helps with early intervention strategies for children with risk for cerebral palsy. So these are kind of models which are out there, and the common theme which you can see is all are involving family. There is lots of everyday activities which are being targeted, and there is attempts of these models being kind of adapted to local and making it more and more culturally sensitive. So next, I would like to talk about a case example. So this case example is close to my heart because this was a program which we initiated when I was working in ICRA Tunnel, and we had actually started this program for NICU graduates. So meaning it's neonatal intensive care unit graduates who are at high risk for development disabilities. So we gave this intervention when the families were in NICU. So we gave them inputs at NICU, and we followed these families in a regular interval to look at how the development is going using very simple tools which could be kind of scaled up. And we kind of had a plan when we had to step up and we give more intervention. So most of the families just received development surveillance, some received some brief inputs to kind of help with their developmental trajectories, and some required more intensive inputs. And from this experience now, it's almost 5 years since this program has started. And what we have found was that it has helped with early detection of problems, and it has really made an impact on improving the development trajectories, especially in motor milestones as well as speech milestones in many of the young people which we saw in this program. But the challenges which we saw also was that there are challenges in terms of parental engagement. So we need to kind of work on that aspect of it. And there are also challenges in terms of data quality, which is quite important when you look at evaluating the effectiveness of these programs. And so that are the two major challenges which we are currently working on. So apart from these challenges, which I described earlier, in terms of low and middle income countries, there is still stigma, which is quite a barrier in this in these conditions, because there is the stigma kind of makes it more and more difficult for families to access services. Also, we all know that when you come to low and middle income countries, there is challenges in terms of infrastructure, workforce, specialist workforce gaps which are there. There is also funding shortages which are there, and there is limited cross-sector coordination, which is not just a problem in low and middle income; it's also a problem in high-income countries as well. And added to that, there is limited research, which I mentioned earlier as well. So, what are these potential solutions for these challenges? So, I would kind of, this is my own kind of opinion and my own kind of experience sharing here, really. I would kind of look at solutions in three dimensions, really. So, one is about co design and co production, second is about data driven quality improvement, and third is about digital innovation. I think these three factors could kind of help with addressing some of the challenges which we have in this area. So when you come to solution number one, potential solution one, that is co-design and co-production. So what I mean by here is that we need to have such meetings more. We need to have more interaction between the policymakers, the families, the clinicians, and the educators, so that we can co-design these programs, whatever intervention which we are developing. And that would kind of help with making it more relevant to them and all stakeholders involved. And it also builds in a kind of ownership to the program as well. It ensures that these programs are culturally fit and it's feasible as well. So we have to look at, when we look at designing such programs, we have to look at what kinds of tools are available, what are the best tools which we can use, which are these tools culturally fit for the process, for the model. And we also have to look at what kinds of strengths are there in these communities, what could be used to integrate to these models, and what kind of process we can build which are culturally sensitive as well, and what kind of outcomes are we looking at which are relevant to that community. So these are the kind of things which could be helped by making all the stakeholders involved in developing such programs. And apart from that, it also creates common language, so it can help with making making language accessible to various stakeholders involved. It creates accountability in all the stakeholders, and it helps with sustainability as well. So it is quite important to have such an approach when you're developing uh, early intervention models. Apart from all these, it also kind of contributes to the bridging between the research and practice. So that's another advantage of having such a focus about making the program more co-designed and co-produced. The another potential solution which I want to put across here is the data-driven quality improvement, which is quite important. We know that there are lots of clinical trials. Usually the clinical trials, what happens is are in ideal conditions, and that is not what we see in real life. The other problems with clinical trial is that it may not be inclusive of people who have severe difficulties. So these are challenges which we have. So what we can do is we can make the clinical trials more pragmatic, more naturalistic, but that there is a limitation in how far we can go with that. So what we need is to have routinely collected good quality data that could be used to evaluate intervention in real world setting and make it more inclusive for everyone involved. This is quite important when we go ahead. But there are certain challenges when we look at these databases as well. So we need to make sure these databases are anonymous, and it should also be quite secure. And these are challenges in these times when we create these databases, and we need to kind of appropriately look at those aspects. And apart from helping with research and quality improvement, these databases also kind of helps with integration between services as well. So we need to think about when we build these databases how we can integrate these data across services from health to social care and other governmental and non-governmental organizations. So how we can kind of integrate. Apart from health, social care, education is also a crucial sector which is involved in such models. And again, when you look at data, always the worry about consent and stakeholder involvement. So again, we need to go back to that premise about how we can ensure consent is taken in these activities and how we can involve as much stakeholders as possible when we develop such models. And so, what are the advantages when we have such data-driven processes? It helps with focus on what works and for whom and which context. It helps with cost effectiveness assessment. It helps with how such intervention can have impact on long-term outcomes. And what outcomes are we looking for? So we can have a discussion about that, and we can work on that. And it is a way where we can have this constant innovation and constant quality improvement practices embedded within the system. Apart from all that, again, going back to research as well. So it's not just quality improvement, it helps with research as well. There can be certain research questions as well, which we can address using such databases. And coming to potential solution number 3, which is about digital innovation. So when you have difficulties in terms of affordability, costings, this is a key area which we need to look at. So what are the so there are certain digital tools which can help with supporting access, supporting assessment, supporting monitoring, and even navigating care. So there are digital supports which can be developed for people to get access to what kind of care is appropriate for their child, even professionals to understand what kind of care is available in their locality. So these kind of things can be helped by digital tools. It can also help in reducing the workload. So you can use digital tools to kind of reduce the workload as well. Again, we need to kind of build these tools in consultation with various stakeholders to make that possible. Helps in scaling in intervention. So if we develop some tool, digital tool in a particular community, we can use those good practices that can be shared easily when we have digital tools using when we are using that. And also having digital tools helps with getting good quality data as well. So because there is less likely there is errors, and it helps with real time recording of data. So in that sense, digital tools helps with the quality of the database as well. When you come to Kerala, there is significant potential in terms of digital readiness. And we have significant, across India, like then we have Bangalore, where there is lots of potential in terms of helping with this digital transition as well. That is important because if you when you go for these digital tools, the main worry is whether we are excluding people who are not digitally literate. So we need to kind of support that digital inclusion when you think about developing such tools. And again, coming back to privacy and data security, which are also major concerns which we need to look at when we are thinking about digital innovation. So, to conclude, what I want to kind of emphasize here is that there is evidence coming through in terms of people trying to collaborate between various, in terms of international collaboration. So they are developing research which is done in high income countries are being kind of adapted to local setting, and it is being kind of driven. Like for example, when you look at the UK Pact, and now it's gone into is being developed into PASS for South Asian setting, and now they are running a trial called Compass trial, which is also looking at how we can kind of in a larger scale how we can embed this practice in whatever systems which are already there, like for example district early intervention centers under the RABSK and other NGOs who are working in these areas. So that could be that is a message of hope there. And we have evidence that family intervention is the way forward. We need to embed these practices in the natural setting, natural activities. And one thing we have to remember is there is a possibility that we kind of give the burden entirely to the families, and that should not happen. Actually, we need to kind of work around ways where we can support the families in their natural activities, but also support them in ways like having centers or places where they can get respite. The child can go some places where they can have some activities, and the parents can take some time off as well, because that is also important. And the key for solutions which I described is mainly the community participation, integrating the digital innovation and good quality data, which is quite crucial if you're looking for a sustainable long-term solution for difficulties like development disabilities. Thank you for listening. And if you would like to contact me, I have given my contact details here, and happy to be in touch. Thank you once again. Hello, everyone. Happy Children's Day. What a great day to talk about.
There is a car, black car, KL84C3805, parked in front of the gate. Please shift the car into the basement.